Bismillah ar-Rahman ar-Rahim. Welcome in our usual scientific meeting of Egyptian Society of Nephrology and Transplantation, CME online meetings. Today I can say clearly that it is the president meetings. We are honored today to have our speaker, Professor Hassaballa, the president of Egyptian Society, current president of Egyptian Society of Nephrology and Transplantation, and the moderator is Professor Ayman Rifai, President-elect of Egyptian Society of Nephrology, the Chief of Nephrology Dialysis Center in Mansoura, Nephrology and Dialysis Center in Mansoura University, and the Vice President of Mansoura Nephrology and Dialysis Transplantation Center. Our topic today is one of the hot topics in transplantation. Professor May will speak about plasma exchange in kidney transplantation, and I expect to hear a lot of information and heavy discussions at the end. And I would like to welcome all of you, all of our colleagues attending this session, and all of our professors attending and will share us with their opinions and very, very, very hot discussions after the lecture. I will leave the floor to Professor Ayman to lead this meeting, and welcome you again, and welcome Professor Ayman and Professor May. Please, Professor Ayman, start.
Thank you very much, Professor Yasser. First of all, let me thank you for choosing this important issue to be discussed tonight. Because as we all know that beside the conventional medical therapies, therapeutic apheresis or plasmapheresis has become an important adjunctive or alternative therapeutic option to immunosuppressive agents, either for primary or secondary kidney disease or kidney transplantation as well. It's my pleasure to moderate this session, and it's my honor to introduce one of the nephrology figures, our dear Professor May Hassaballa. Professor May is the president of the Egyptian Society of Nephrology and Transplantation, and she is also the representative of North Africa in the Middle East Society of Organ Transplantation in Minnesota. Professor May is going to address in details, I think, this important role of the plasma exchange in the field of kidney transplantation. Please, Professor May.
Thank you very much for the introduction, Professor Ayman, Professor Yasser. And now I'm going to share my screen. Okay. So the talk today is going to be on plasma exchange in kidney transplantation. And the agenda will include the definition, history, principle, techniques, and then I'm going to speak about the indications in kidney transplantation. So the word aphoresis is a Greek word that means to remove, to take away from. So when you remove the bad things that you want to remove and you return the healthy things, this is aphoresis. And when you remove the plasma, and which case you will have to give substitution fluid, this is going to be plasma exchange. So the history is sorted first, was described in dogs in 1914, and then 1960, it was performed in a case of macroglobulinemia, and 1975 in Goodpasture syndrome, 1976 SLE, and 1977 in TTP. And the principle of plasma exchange is one important thing is removal of large molecular weight pathogens. And these could be antibodies, immune complexes, cryoglobulins, light chain proteins, or cholesterol containing lipoproteins, also toxins and drugs, or substitution of necessary or deficient substance. So removal of or substitution of something does not really address the original pathology of the disease, and antibodies usually increase after the plasma exchange with proliferation of the B cells. So immunosuppression is usually given in conjunction, and we have to consider IVIG and or solvent detergent treated plasma. Another role of plasma exchange is an immune modulatory effect, which is still controversial, but it does seem to affect the immune responses of the cells. The substitution fluids, as you all know, are the plasma products: fresh frozen plasma, stored plasma, cryosupernatant plasma, solvent detergent treated plasma, and human serum albumin, 5%, which limits the exposure to plasma antigen and lipid-soluble viruses, so there is less infectivity, and it's less allergic, no ABO compatibility, but there is an increased risk of bleeding because it does not provide coagulation factors, and there is increased risk of infection because it does not replace the immunoglobulins and is more expensive. Of course, you can combine both together, and you can also combine crystalloids and colloid solutions. So what are the therapeutic aphoresis techniques that are performed in the setting of kidney transplantation? We have the centrifuge-based therapeutic plasma exchange and the membrane-based, but we also have more selective therapeutic aphoresis techniques, which are the double filtration plasma apheresis and the immune absorption. There are other techniques which are not commonly used in kidney transplantation, so I'm not going to speak about those right now. We have the cryofiltration and the extracorporeal photopheresis and the selective plasma absorption, like when you remove the chylomicrons with special ligands. So let's speak about the plasma exchange, starting with the centrifugal form, where the blood is passed through a rapidly rotating centrifugal chamber that will separate the cells from the plasma by the density, and then the plasma is going to be discarded, and the cells will go back to the patients together with the colloidal replacement fluid. Now, it has a very effective plasma removal efficiency, and it works at a blood flow of 550 mils per minute. So it doesn't really require to have a AV fistula or a central venous catheter, which of course is going to spare the complications that you all know of central venous catheters with the infections, the bleedings, and the thrombosis. Whereas as the membrane-based plasma exchange is the plasma is going to be removed through the hollow fiber membranes, which in this case depends on the size of the pore size, and then the plasma is going to be discarded, and again the same thing happens. The blood or the cells will be returned back to the patient together with the colloidal replacement solution, and it is associated with this platelet loss and less hemolysis, and it can be used using the regular dialysis machine, and it is faster. But at the end of the day, they both seem to be similar in efficacy. So, of course, the plasma removal efficiency is less for the membrane plasma exchange, and the blood flow is higher. It is in the range of 150 and 200. So, in this case, you would have to have AV fistula or a central venous catheter. So these are the differences, as you can see here, for the blood flow is about 150 to 200 in the membrane, and extraction is higher in the centrifuge. It's 80% compared to 30%. Anticoagulation citrate here in heparin in the membrane, and well, separation depends on specific gravity, and it depends on the size. Serialization, gamma irradiation, ethylene oxide, whereas it's ethylene oxide in the membrane aphoresis, and the fluid replacement is the same. But again, they both have the common thing is that they are non-selective, which means that you are losing the plasma, you are losing the plasma proteins, including the albumin and the coagulation factors and the immunoglobulins. You're losing all that. So let's speak about therapeutic aphoresis techniques. And here we have the double filtration plasma apheresis. And here you have two membranes. One is the normal plasma separator, which removes the plasma as usual. And then it passes through another plasma fractionator with different pore sizes that are targeted to remove special macromolecules. Most probably it's immunoglobulins. So in this way, smaller sized molecules will be returned back to the patient. So this is going to spare up to 70% of the albumin loss during the the non-selective plasma apheresis. And of course, there's going to be a reduction in the need for replacement fluids. This is even more selective, which is the immune absorption, where again, you have the regular membrane to separate the plasma, and then it passes through two columns these columns are have the immune sorbents already prepared in these columns. So these could be bearing, the columns could bear antigens directed against certain antibody or antibodies against certain plasma constituents. So this could be mobilized sheet polyclonal anti-human IgG antibodies, which are used to remove IgG antibodies from the plasma, or it could be, well, of course, in this case, you will have to return, you can return back the coagulation factors together with the albumin. Or it could be immobilized antigen epitopes, thus removing the pathogenic antibodies only. So this is very specific because the rest of the antibodies can be returned to the patient. So this is very specific. Or you can have immobilized staphylococcal protein A, which effectively clears IgG types 1, 2, and 4 by binding their Fc portions. Now you can see that there are two columns. One is being used and the other is being regenerated by washing fluids, so they can use interchangeably. So this is going to allow more plasma to pass and more efficient removal of immunoglobulins. Now, for the guidelines of aphoresis in general, plasmapheresis is going to be performed daily or every other day, and the minimum course should be 10 to 20 days. And it's divided into different categories, 4 categories. Well, the first category includes disorders in which aphoresis is accepted as a first-line therapy, either as a primary standalone treatment or in conjunction with other modes of treatment. Category 2 are disorders for which aphoresis is accepted as a second line, and category 3, the role is not established. Category 4, it's ineffective or harmful. Now let's move to kidney transplantation. And here, what are the clinical indications? So the most important indication is incompatible transplantation to desensitization for ABO and HLA incompatible transplantations. And these are the only conditions where you use plasma exchange before transplantation. We also have antibody-mediated rejection, and other indications include the recurrent FSGS, Thrombotic Microangiopathy, either due to recurrent atypical HS in most cases, or de novo TMA. And we have recurrence of ANCA-associated vasculitis and Anti-Gdm disease, which could be recurrent or de novo. And finally, we have antiphospholipid syndrome. So these are the indications for plasmapheresis related to transplantation. So starting first with desensitization, we can have desensitization for ABO incompatible transplantation or HLA sensitization, which occurs in 35% of the waitlist patients. ABO incompatible transplantation was a complete contraindication in the past because of the occurrence of hyperacute rejection due to the presence of preformed anti-B and anti-A antibodies, isoheme agglutinins. And of course, these are very well represented, expressed on the endothelial cells as well as the kidney parenchymal cells. So plasma exchange plays a cornerstone in the management of ABO incompatible transplantation. ABO incompatible kidney transplantation accounts for approximately 30% of all living donor kidney transplantation performed in Japan. And this study comes from Japan. It was done on almost 2,000 patients between the years 1989 to 2010. And you can see here, if you look at the yellow line, it's all the cases together, combined together. The 5-year patient and graft survival were 95% and 90%. And the 10-year survival was 93 and 84%, which is very much similar to compatible transplantation. What they did is that they started the immunosuppression 4 weeks before transplantation, and they used tacrolimus or cyclosporin with MMF. And then 2 weeks before transplantation, they gave rituximab. So they're using T-cell mediated and B-cell mediated immunosuppression. And then they start the plasmapheresis. The sessions could range from 1 to 11 sessions usually. And then we give induction therapy, and there occurs rise in antibodies after 1 or 2 weeks from transplantation, but this does not really correlate with occurrence of antibody-mediated rejection because of a phenomena of accommodation, which is not very well understood. The seems to be a change of the antigen or the antibody, that they no longer trigger immunity against each other. So the most widely used are the plasma exchange, and selective immunoadsorption is the most efficient to remove the antibodies. And in cases in which plasma exchange are used, substitution with albumin or fresh frozen plasma is needed, but fresh frozen plasma should be both donor and recipient ABO compatible. The aim is to target the post-procedure isoagglutinin titers to less than 1/16, and the number of procedures will vary according to the baseline isoagglutinin titers. And there is a debate about the post-operative immune adsorption, if it should be given routinely, as to say preemptively, at less frequent intervals, or on demand with a cutoff for antibody titers in the first week of 1/8 and second week 1/16, or not at all, as there is an immunologic accommodation for elevated titers. And a group of Johns Hopkins hypothesized that post-operative therapeutic plasma exchange could be helpful in preventing the rebound of anti-A and B titers until tolerance or accommodation occurs. So there's no definite consensus for the post-operative plasma exchange or immune adsorption. Now let's move to HLA sensitization, and definitely you all know that there is a survival benefit with kidney transplants from HLA incompatible live donors. And if you look at that study, it was done more than 1,000 HLA sensitized patients from 22 centers in the years between 1997 and 2011. And what's peculiar about this study is that it was followed up for 8 years. And if you look at the upper line here, these are the patients or the recipients of incompatible transplants. And the second line are those on the wait list or received cadaveric transplantation. And the blue lines, those are the wait list only control group. Definitely, there was a significant survival benefit observed at 1, 3, 5, and 8 years post-transplant. And this was clearly shown in all levels of donor-specific antibody, positive Luminex assays, positive flow cytometric cross-match, and positive cytotoxic cross-match, and etc. So of course, if you have this recipient, if this recipient has antibodies against this donor, the best thing to do is to use another donor to this recipient, and you let this donor donate to another recipient with no antibodies against. And this is the idea of paired donation. So, and this is very important to reduce the need for desensitization. But again, even those patients who are hyper sensitized with calculated pan-reactive antibody, 99%, those patients will need to have both the desensitization as well as the paired donation together. So the desensitization protocol that you all know is that we're going to have a plasma apheresis IVIG. We can use the high dose 2 gram per kg at the end of the sessions, or the low dose 100 milligram per kg after each session, together with rituximab or other immunosuppressive medications. So it's daily or every other day until the cross-match becomes negative, usually 5 to 8 sessions. Albumin is used as a replacement fluid, and there is some debate about that because some are afraid that albumin may result in bleeding during the surgery. Some vote for fresh frozen plasma. IVIG is given as mentioned, and some protocols use MMF and tacrolimus 14 days before transplantation, and rituximab is also used in some protocols, and the induction therapy is used. And transplantation occurs within 1 week of last desensitization treatment. Anti-HLA antibody titers rebound within few weeks after treatment stops. So plasma exchange is performed in the first week post-transplant, and post-transplant monitoring is very important because timely treatment of antibody-mediated rejection is very important. The use of therapeutic aphoresis and HLA desensitization in the diseased kidney transplantation had conflicting results. So as such, the desensitization for HLA is a category 1, whereas for the deceased kidney transplantation is category 3. Of course, you monitor with the antibodies, but you can also do protocol biopsies because you all know that you can have the evidence pathologic injury before any clinical evidence or change in serum creatinine is available. Now we move to antibody-mediated rejection, and this is occurring post-transplant, of course. It occurs in 5% of patients with compatible kidney transplants and in 50% with incompatible kidney transplants. Could be due to anti-HLA antibodies, non-HLA antibodies, and anti-EBO less commonly. So, of course, you know that the HLA antibodies could be preformed antibodies, which commonly occurred due to previous blood transfusions, previous transplantation, repeated pregnancies. But those which occur post-transplant are due to under-immunosuppression or lack of compliance. But please remember that you also have the memory cells, and you can have this producing antibody that were not identified before the transplantation. It is the most important cause of allograft loss, and many cells are contributing to produce this rejection, and many drugs are used to treat different cells. And of course, the plasma exchange comes with the removal of antibodies. Now, I got this slide from the ATC 2020, which shows that the histology is the same, but we have different phenotypes, and the drugs that usually the response to treatment occurs in the pre-transplant DSA with early allograft dysfunction, whereas the late antibody-mediated rejection response to treatment is usually not very good. Especially for the de novo antibodies, which occur 10% first year and then 3 to 4% each year thereafter. And of course, this is associated with marked reduction in the graft survival. So the many drugs under study, of course, and among which the double filtration plasmapheresis is also one of the challenges that under study as well. So you give intravenous methylprednisolone 500 milligrams daily for 3 days, and then plasmapheresis at least 5 sessions of full plasma volume on alternate days. Further changes will depend on the initial MFI of the donor-specific antibody and response to treatment. And IVIG is mentioned, and you consider rituximab or other immunosuppressive drugs. You check the DSA after the last plasmapheresis, and you send sample before IVIG is administered or at several days later, as it may lead to false positive results. So the antibody-mediated rejection is a category 1, whereas for ABO incompatible kidney transplantation, it is category 2. Now we move to other indications apart from incompatible transplantations. We have the recurrent FSGS. Recurrent FSGS occurs in 30 to 55% of kidney transplant patients, and the risk in the second transplant is 80% or more. It may occur within hours or days of grafting. It's believed to be due to circulating permeability factor, and there are no randomized controlled trials, and the recommendations are based on uncontrolled studies or case series. The risk factors for recurrent FSGS are the early onset in children less than 15 years and aggressive course of the disease of the native kidney with rapid progression to end-stage renal disease and loss of a previous allograft from recurrent FSGS. So this is to show you that the use of plasma exchange or immune adsorption is going to result in reduction in proteins, but then it's going to recur again after stoppage. So for treatment considerations, we use daily proteinuria. Testing is very important for at least 14 days after transplantation. And if proteinuria is detected, immediate initiation of plasma exchange therapy is recommended. Guidelines recommend 3 daily exchanges followed by 6 every other day, subsequent 2 weeks for a minimum of 9 procedures with concomitant immunosuppressive medications, and long-term regimens of weekly to monthly exchanges depend on the degree of proteinuria may be required to achieve remission. This is considered to be category 1. So there are still unanswered questions like which replacement fluid to use. Is it the 5% serum albumin solutions versus the fresh frozen plasma? And the duration of plasma exchange treatment after remission, and the efficacy of pre-transplantation plasma exchange. Now it appears to be not effective to prevent recurrence. Now we move to thrombotic microangiopathy, and this paper here speaks about thrombotic microangiopathy, an underdiagnosed and potentially reversible entity. We have the recurrence, which is mainly due to atypical HSS, but you can also have antiphospholipid syndrome, a TTP, and autoimmune disease. And you have de novo, which is more common. It's 90 versus 10% of all cases. And of course, the drugs that we use for transplantation, antibody-mediated rejection, the viruses that we commonly encounter, ischemia, reperfusion injury. We can also have a transform from native kidney C3GN and unrecognized recurrent TMA. So you know that speaking of the atypical HAS, it's mainly due to a defect in the genes of the complement regulatory proteins, the complement factor H and complement factor I, which are fluid phase proteins, and we have also the membrane compactor protein, which is the membrane-bound proteins, and they all work to stop the continuous activity of the alternate complement pathway and the formation of the terminal complement components that will result in endothelial injury. They are very common to recur after transplantation. In spite of that, they are very rare, but their recurrence is very common, and the graft failure is very high, especially for the complement factor H and complement factor I. This is not the case with membrane because it's attached to the membrane. So when you transplant a new kidney with a different membrane and things are changed, unless the donor himself has a problem with these mutations. And these are loss of function mutations. Other causes are the presence of complement factor H autoantibodies. And we also have gain of function mutations. So these are all conditions that can result in loss of the graft. So what plasma exchange is going to offer is going to remove the circulating autoantibodies to complement regulators, is going to remove the circulating mutated complement regulators, and will replace the missing or defective complement regulators. So the guidelines is that you do plasma therapy starting within 24 hours of presentation and with an exchange of 1.5 plasma volumes per session with fresh frozen plasma. Here, you should use fresh frozen plasma for compensation. And you do it daily for 5 days up to 2 weeks during the acute phase. And subsequent frequency is 5 times per week for 2 weeks and then 3 times per week for the subsequent 2 weeks until the platelet count and LDH and hemoglobin levels have normalized and renal function shows signs of improvement. Now, with the advent of the anti-complement 5 antibody, the eculizumab, it has resulted in a better outcome and has challenged the role of plasma exchange in this condition. But there is still a role of plasma exchange for treatment when eculizumab is not available, or when thrombocytopenia is still present during the first days of eculizumab administration, and in patients with anti-complement factor H antibodies. It also has a role in prophylaxis, besides other than eculizumab, again, in conditions with complement factor H autoantibodies. And in intensive plasma exchange in absence of eculizumab can be used for the mutations affecting the plasma complement components, either with kidney liver transplantation or single kidney transplantation with intensive plasma therapy, which is going to be long-term in this case. There are studies on living donor kidney transplantations and indicating a good response without eculizumab, but actually they were done on a small number of patients. Now we move to the de novo, and of course we have the drugs that are used in kidney transplantation, immunosuppressive medications, and viruses and antibody-mediated rejection and ischemia reperfusion injury. So how do you deal with these conditions? The first of all, you treat the cause. Some people prefer to start with plasma apheresis in the case that there could be a genetic background for the patient, because this is not uncommon to have a genetic background and then you need a second hit for this thing to appear. But what we usually do is to treat the cause. However, there is a role of plasma exchange when you do changes in the drug and immunosuppressive medication, and you treat the virus and you find no response. There's going to be here a role for plasma exchange. Is there a role for eculizumab? in patients who become plasma exchange dependent, and in those refractory where the refractory hemolysis persists despite maximum dose of plasma exchange therapy, and of course, an antibody-mediated rejection with thrombotic microangiopathy. And if this eculizumab is available, and the best thing is to use it earlier in order to save the kidney. Now we move to the recurrent ANCA-associated vasculitis, and actually relapsing kidney transplantation is a rare event. It occurs in around 10% of the cases. In the case of recurrence, the treatment options for remission induction are similar to those of non-transplanted patients. So therapeutic plasma exchange is recommended in conjunction with glucocorticoids and either cyclophosphamide or rituximab in the setting of relapse, manifesting as alveolar hemorrhage, severe segmental necrotizing glomerulonephritis with serum creatinine above 4 milligrams per deciliter, and concurrent anti-GBM disease. Generally, 7 to 12 procedures are needed. In alveolar hemorrhage, the substitution fluid for plasma exchanges fresh frozen plasma in order to avoid further increase in bleeding. It is recommended in patients with ANCA vasculitis and end-stage renal disease transplantation to be delayed until a complete extrarenal remission for at least 12 months is achieved. This has category 1 for the dialysis dependent and the diffuse alveolar hemorrhage, category 1, whereas in the dialysis independent, it is category 3. If you look at the antiglomerular basement membrane that we're going to speak about shortly, it is different in that the dialysis dependent is category 3, whereas the dialysis independent is category 1. So anti-GBM disease, we have the recurrent and the de novo. It is caused by circulating antibodies directed against a non-collagenous domain or the alpha-3 chain of type 4 collagen. It's very rare, occurring in 0.5 to 1 cases per million. So we don't have high quality randomized control trials to base treatment recommendations. The disease recurs in up to 50% of the cases post-transplant. And we have de novo anti-GBM disease occurring in patients with Alport syndrome, because those patients have defective in the collagen 4 with missing alpha-3 and alpha-5 chains. So when they get transplanted, then the transplant will express the alpha chains, the normal alpha chains that are going to trigger immune response. This de novo anti-GBM occurs in 15% of the Alport patients after kidney transplantation. So generally, treatment is performed as per native kidney with anti-GBM disease. Therapy should be initiated as early as possible. Plasma exchange is performed daily or every other day, and anti-GBM antibody titers should be monitored, and the procedure should be performed until the autoantibodies are undetectable. It takes approximately 10 to 14 sessions. Plasma exchange is combined with steroids and cyclophosphamide, and the role of rituximab is currently unclear. So the presence of detectable autoantibody titers prior to kidney transplantation is a well-established factor for recurrence, and therefore a period of at least 6 months of undetectable anti-GBM antibodies is recommended prior to kidney transplantation. Now, finally, the antiphospholipid syndrome. Now, this is a multisystemic autoimmune disorder characterized clinically by thrombotic episodes in the arterial or venous circulation, and serologically by the persistent evidence of antiphospholipid antibodies. Catastrophic antiphospholipid syndrome is characterized by diffuse TMA with vascular occlusions involving 3 or more organ systems. Antiphospholipid syndrome occurs either as a primary condition or secondary in the setting of underlying systemic autoimmune disease like lupus. The data for catastrophic antiphospholipid syndrome after kidney transplantations are limited, and the presence of antiphospholipid antibodies is a recognized risk factor for recurrence. Early graft arterial or venous thrombosis, or TMA, remain the most frequent cause of renal graft failure in patients with antiphospholipid syndrome. Treatment of antiphospholipid syndrome with long-term anticoagulation is recommended after kidney transplantation, and in spite of that, graft thrombosis occurs in 40% of the cases. So plasma exchange is used for prophylaxis and treatment in combination with steroids and anticoagulation. This is very important, plus minus IVIG. And plasma exchange in catastrophic antiphospholipid syndrome is performed daily or every other day, and substitution fluid is usually fresh frozen plasma or a combination of fresh frozen plasma and albumin. Cyclophosphamide, eculizumab, and rituximab are also used in the treatment. And there's some evidence that the use of eculizumab can prevent recurrence of catastrophic antiphospholipid syndrome after kidney transplantation. And thank you very much for your attention.
Thank you very much, Professor Mai. I really enjoyed the talk. Really, you elegantly addressed and covered all the aspects of the use of plasma exchange in kidney transplantation in a comprehensive but in a simple way as well. And you showed us clearly that the therapeutic aphoresis is a well-recognized option for increasing the donor pool by treating the HLA sensitized patient and making the ABO incompatible kidney transplantation possible. Also, you showed us that post-transplant, plasma exchange is very important in treatment of antibody-mediated rejection and in the have a place in the treatment of recurrent and post-transplant glomerular disease. Let me start a question about you showed us the different indications of plasma apheresis in kidney transplantation. My question about the substitution fluid preference, which is preferred in all these indications? I mean, in the desensitization and the treatment of antibody-mediated rejection, is fresh frozen plasma is less preferred in this situation, and albumin is more preferred, and the other indication, what is the more preferred substitution for each indication you mentioned?
Okay, so for desensitization, it's recommended to use albumin, yes. but just they don't want to expose the patient to fresh frozen plasma before transplantation for the possibility of infection or sensitization or allergic reactions. But again, there is the fear that albumin alone may not provide the coagulation factor, so there is a risk for bleeding after transplantation. But the most of the consensus goes for albumin more. In the treatment of antibody-mediated rejection, it is the use of fresh frozen plasma or a combination of albumin and fresh frozen plasma for the desensitization.
You don't think that the fresh frozen plasma may be a source of sensitization with its components of new antibodies from other source, or I mean, we could increase the sensitization by using these plasma with different antibodies?
Yes, of course, each one has its pros and cons, but this is the consensus so far. So the use of fresh frozen plasma was stated in the consensus that was given in 2019, and it was also presented in the ATC in 2022. They were recommending to use fresh frozen plasma, but of course, there could be drawbacks to that, and the combination in this case may be helpful. يعني كل حاجة هيبقى ليها مشاكلها.
In your practice, Dr. Mai, in your practice for treatment of antibody-mediated rejection, do you use fresh frozen plasma or albumin?
I use a combination. I use combination of both, actually.
In the same session or in different sessions?
Same session.
In the same session, you combine albumin and
fresh frozen plasma.
Excuse me to interfere with this point, Professor Ayman and Professor Mai. Usually in plasma exchange, as Professor Mai said, after the second or the third station, there will be exhaustion of plasma coagulation factors and proteins, and we are in need not to use only albumin at this point, especially after the second and third station. All of the indications we need to use a substitute by
ياسر الصوت
راح دكتور ياسر.
After the second or third session, usually we are in need for to use plasma for the exhaustion of coagulation products and plasma proteins, other plasma proteins. And in special indications such as DMA, I think Professor Mai, we are to use plasma.
Fresh frozen plasma. Yeah.
Fresh frozen plasma.
Fresh frozen plasma is indicated for thrombotic microangiopathy, of course, and it's also indicated only fresh frozen plasma to be used in the presence of alveolar hemorrhage in the ANCA-associated vascular.
In all indications, even in non-transplantation conditions, we are to use, especially after the second or the third session, a combination of both replacement solutions.
Yes.
Thank you for your response.
And also, what do you prefer, Professor Mai, the centrifuge method or the membrane? Or they are the same according to the availability?
Theoretically, they are efficiencies the same, but we use the membrane because it's easier for us, and we have the machine membranes.
Professor Halawa, I see that you have a lot of questions. You are muted.
Can you unmute me?
Yes. Yes, we hear you.
Thank you very much. Thank you very much for this elegant presentation. Actually, it was so informative and also is not exhaustive. So we didn't feel bored at all.
Yes.
Really, very enjoyable. Basically, regarding the fresh frozen plasma, we use octoplast, which is a pooled human plasma, all the time. We shouldn't forget that, if we deal with plasma exchange or plasmapheresis prior to transplant or shortly after transplant, there is high incidence of bleeding. So, and we had many bleeding, episodes. One of them was very dramatic. And this is why we are very keen on octoplast, which is fresh frozen plasma all the time to replace the clotting factors. So I totally agree with Professor Mai that fresh frozen plasma is essential because remember, antibody-based rejection occurs shortly after transplant in highly sensitized, quite expected. Don't forget, this patient had a biopsy again. So we have kidneys lost because of bleeding from the biopsy. So, so it's very essential to replace the clotting factors. And this is regarding the APA incompatible. Actually, when we have increasing the theta of 2 logs, again, we plasma freeze these patients. In the past, we didn't know what to do after ABO incompatible transplant. We kept following the theta, we didn't know what to do. But the recent guidelines suggested that if you have 2 log increase in the APO theta, you should intervene. And that's it really. And no other comments. Very, very enjoyable. And actually, it's very nice, Professor Mai, that you presented and talked about paired exchange, because if we have paired exchange scheme, this will resolve all this mess. APO incompatible with these complications, highly sensitized patients as well. So, and the desensitization with complications and the cost as well. Cost is massive. Yes. For transplanting highly sensitized patients. So paired exchange saves money and also, improve the graft survival compared to transplanting highly sensitized patients. Because of the paired exchange scheme, we haven't done any highly sensitized ABO transplant for the last 3-4 years. Because we have very active paired exchange scheme. So I encourage, everybody just to think about the paired exchange scheme. There's no science behind it. It is just system and organization and communication.
Exactly.
Yeah. And thank you very much, Professor Mai, for this elegant lecture.
Thank you, Professor Halawa. And thank you for joining when you're not feeling well, but you did join. You could make it. Thank you.
Thank you.
Thank you, Professor Halawa, for the valuable comments. I have a question from the floor about the use of plasma exchange in BK virus infection and CMV.
I don't have experience in that. I've never used it in this condition, so I don't know if anybody has any experience.
Never heard of plasma exchange in BK
yes.
with CMV.
Yeah,
Professor Ayman, we have another question from the floor from Dr. Khaled Abu Zaid asking about the use of plasma exchange in recurrent FSGS. Is there is a relation to the level of proteinuria? And another question from Dr. Khaled also asking about the use of exchange in catastrophic antiphospholipid syndrome in non-kidney transplantation.
طب معلش قولهم تاني بقى كده.
أول حاجة أول سؤال related to transplantation is level of proteinuria. Is there any relation of level of proteinuria?
Yes, of course, of course. We actually start the plasma exchange when we detect any proteinuria, and it has to be done immediately after detection of proteinuria, because we don't know what is the thing that we're looking for in the blood, that is what is the circulating factor. So we depend on the proteinuria, and we follow up with the proteinuria, and we maintain the sessions as long as we have proteinuria. And the problem is that when we have remission, should we stop or not? These are some difficult questions to answer, but we may need to maintain for a long time, for months or maybe years, depending on the proteinuria.
Depending on the proteinuria, and he is asking, is proteinuria only, or any other markers to use to start plasma exchange?
Proteinuria, because proteinuria is the first thing that's going to occur before any more damage will occur to the graft. So start with the proteinuria, of course, yeah.
Okay. Yes, Professor Ayman.
We have another question from Dr. Muhammad Saftawi about the use of pre-transplant plasmapheresis in focal segmental glomerulosclerosis in order to prevent recurrence. I think the
Pre-transplant has no role.
Yeah,
has no role.
Okay. Question to Professor Halawa. You mentioned that you follow up the titer of the isoagglutinin after transplantation in case of the ABO incompatible.
Yeah,
okay?
for a year.
For how a year?
Yeah, absolutely.
For a year. And the frequency is?
A whole year for after ABO incompatible?
Yeah, actually the whole year, but not every month.
Yeah, I mean the frequency. Yeah, okay.
Every 3 months.
Every 3 months for a year.
For a year.
Then you stop estimating the isoagglutinin.
Absolutely.
Okay.
We didn't have any problem, honestly, because if you have a lower theta, you are on the safe side. The guidelines and the BTS guidelines recommended, as Professor Marian said, 1:16. But in our unit, we'll put it down to 1:8.
Okay.
So 1:8 is safe, because the problem when you get the theta, there are variability between labs. One lab will give you 1:8, another lab will give you 1:16. So we went on the lower side just to make sure that we have a safe theta. So 1:8. So 1:8, is quite safe. And actually, we do subtyping as well. So ABO incompatible, don't forget that A2 is less antigenic than A1. So we do a lot of, you used to do a lot of A2, and actually the theta is 1:4, 1:2, and even, is nearly negligible. And this is still considered ABO compatible, but still we give, less aggressive treatment, rather than 5 or 6 sessions of plasmapheresis. We give 1 session of plasmapheresis and 1 dose of rituximab, and that's it really. And actually, the guidelines are mentioned that you don't need to do that, but because we are panicking about the living transplant, so we give just a bit more immunosuppression.
And how often do you use immune absorption, Professor Halal?
None.
None, because it's
Yes.
that expensive.
They're very expensive. Yeah, and don't forget, Professor Mike, that the pairs exchange scheme now, relieved our mind from all this mess. A few centers in the UK, they use it. And actually, immunoabsorption is good actually even for cadaveric transplant, highly sensitized patients, when you give them a cadaveric kidney, because it's so efficient that 1 or 2 sessions of immunoabsorption can bring the HLA antibody titer down and achieve negative cross-match.
Yes.
But with I tried highly sensitized cadaveric and just 1 session of plasma exchange. It didn't touch the titer. at all. So we transplanted this patient against positive cross-match, but there was a different story because it was anti-DP, which is less expressed. But we managed to do well. Just lucky to get through.
Professor May, I have a question about the number of the sessions. I know that it varies according to the indication. For example, for the ABO, as you mentioned, maybe 1 to 12 sessions. For the it's unlimited for recurrent focal segmental guided by the proteinuria. And my question about the antibody-mediated rejection, is it 5 to 6, or you like to extend in some cases, or?
I would say at least 5.
At least 5, every other day.
Every other day.
Yeah, okay.
So Ayman, Professor Faisal Shaheen wants to comment.
Yes, Professor Faisal, please.
Thank you, Ayman. It's very nice to hear Prof today. She's excellent, and she addressed the subject in a very nice way. And
we're happy to have you with us, Professor Faisal. Really.
Thank you. I'm very happy, Prof. May, actually. So, really, it is excellent talk, and it is to the target. But my concern, probably I go with Prof. Halawa about the expense of plasmapheresis. And again, in our situations in developing countries as a whole, still we have to think about the cost of the management. And probably if we go for exchange, donor exchange, this will make less a little bit the problem. But if we are already transplant some patient and he had rejection and he need plasma, we have to do it. We are obliged, but it is still a very expensive sort of management. Especially you have to have another specialty like immunologist on place, and you have to have tissue typing, someone who can check for you immediately how is title of the BRA and things. So it's very expensive and it needs a lot of work. So probably if we go for an early before transplant to choose a good donor and good compatibility, probably it will be less costly. This is just only my concern. Thank you.
Yes. Thank you.
Thank you, Dr. Faisal. Any other
I have
comments?
I have small comments.
Yes.
I forgot to say, actually, not only the titer, which we were looking at, we look at the kidney function, we're looking at proteinuria as well. So it's not only one parameter which is
exactly.
Yeah.
So may go for plasmapheresis in the presence of low titer, but there is bad kidney function or deteriorating kidney function and proteinuria.
But don't forget
without histological diagnosis. Okay.
Have the histology.
Yeah, the biopsy.
Okay. Any other questions? I think you made it clear, Professor May. So
true.
Yeah, very clear, very, very clear.
Thank you.
Dr. Yasser, do you get any questions from the audience?
Looks like he has a problem with connection.
Okay.
ياسر اختفى.
Okay, اختفى.
اختفى في ظروف غامضة.
Dr. Riyad, is still with us?
Yes, Dr. Riyad wants to.
نعم معك.
Okay. Would you like to comment?
محاضرة قيمة جدا دكتورة معي. تعليق اثنين الله يخليكي. I agree with with Dr. Yasser what he mentioned about. I would use human albumin with saline. That's replacement solution. At the end of 2 to 3 sessions, yes, I think I will give fresh frozen plasma to rebuild the clotting factors, especially if the patient is going for surgery or if he's having the biopsy. That's number one. Second, they have a comment about the focal segmental recurrence. I don't know, I missed that part whether Dr. May you mentioned early recurrence versus late recurrence. because I understand early recurrence, yes, plasma exchange is working, it's going to work, but in late recurrence, really, there is no role for plasma exchange. What do you think?
Yes, I guess so. But it's most of the cases, it's early recurrence. What we see is early recurrence, but late recurrence is not very responsive. Yes.
Okay.
There is a question from Dr. Khalid Abu Zaid about if the patient needs hemodialysis and plasma exchange in the same time.
So you can do it alternatingly. Yeah.
And I think we are used for the dialysis unit to have the membrane most of the time. Membrane.
Yes.
I don't think that in the last 2 years I used the centrifuge. Centrifuge is really in the lab. It's laboratory equipment, but the filter, it's the dialysis domain.
Exactly.
Any other comments or questions?
We have, please, Professor Ayman, excuse me. In our last clinical forum, there was a case of transplantation presented by Alexandria University. It was about de novo FSGS late after transplantation. I can remember that it was about 10 years after transplantation. And this was a question that we needed an answer at that session, and we failed to find this answer. Is there a role for plasma transplant, plasma exchange in late de novo FSGS, not the recurrent type after transplantation? If the patient developed de novo FSGS later in transplantation, will be there a role for plasma exchange at this point? Please, Professor May.
I'm not sure, but I really am not sure if it's a de novo FSGS.
Yes, well, there was no history of recurrence. There was no criteria for recurrence FSGS, and it was very late, about 10 years after transplantation. So they diagnosed it as de novo FSGS.
So what did you reach in your meeting? What was the consensus? Yeah, what did you?
Really, we failed to reach a consensus about this point, and we say that we will deal with it as a primary FSGS.
Exactly.
And the role of plasma exchange at that point is not that clear.
Exactly.
So I find it a good chance to raise this issue again for persons.
Don't forget, you know.
I think that, okay.
Sorry.
Yes,
yeah, don't forget the Professor Yasser, plasmapheresis for recurrence FSGS is not strong. There's no strong evidence. It's all about trial, and even all the data based on kids reports and just poorly controlled studies. So this part of of the science is not clear yet. As Professor Mary mentioned, it's a trial to help. And also FSGS, not all of them will fail the kidney, 50% of them will fail the kidney. So it depends on other factors like deterioration of kidney function, the extended proteinuria, and other factors as well. Is it second or third transplant for these patients? Is he running out of access? Many other considerations.
Mm-hmm.
I think, Professor Yasser, to the best of my knowledge, that there is no rule for plasma exchange for de novo focal segmental glomerulosclerosis, as the assumption of the plasma exchange is the removal of permeability factor, which is responsible for the recurrence, and this is not the case in case of the de novo focal segmental glomerulosclerosis. So I think in such cases, just ACE or ARBs, no need for plasma exchange. Antiproteinuric agents only.
We missed you so much, dear professors, in this session, especially at this point. We missed this discussion, and I find it a good chance to raise this issue in discussion again. And this was really the same opinion we reached about that. We did it as primary FSGS and no role for plasma exchange at this point.
Mm-hmm.
Thank you so much.
Thank you. Yes, thank you.
Any other comments or questions?
1 minute, please. 1 second. Preemptive from Dr. Abdallah. Preemptive plasma exchange prevents atypical hemolytic uremic relapse in kidney transplantation. He is commenting. preventing HUS relapse in kidney transplantation, preemptive plasma exchange. Do you find this?
So yes, we do. There has to be, for those patients with atypical HS, they need to have prophylaxis before going into transplantation. And if eculizumab is not available, then you will have to give extensive plasma exchange peri-operative, before, during, and after, for a long period of time. If you don't have the eculizumab, yes, of course, it has a role.
Okay, thank Professor Ayman. No more comments, and no more questions on the chat.
Yeah, I think
يوم خفيف
جدا وجودك دكتورة مي محاضرة رشيقة جدا الحقيقة، في منتهى الرشاقة والصحية. very smart حاجة يعني. في الآخر thank you very much Professor May for this. I really enjoyed the lecture and I enjoyed the discussions. Thank you Professor Halawa, Professor Faisal, Professor Yasser, and all the attendee, and I hope we can meet you in the near future with another episode in transplantation. Thank you Professor Yasser for maintaining this activity in a very smart and elegant way. Thank you very much all.
Thank you. Thank you.
Thank you Professor Ayman for leading this session. Thank you Professor May for your, as usual, very smart, comprehensive talk. Thank you our all professors who shared us and enriched us. Halawa, Professor Faisal Shaheen, Professor Riyad Saeed. Yes, I would like to welcome you every session. More than welcome to join us, and we will be very happy, and our usual happy to for your join and your share. Thank you all our attendees, colleagues, for your share and your discussions as usual, which enriched our session very much. And excuse me to close this session and announce about the coming session will be by Professor Amir Uqail, speaking about treatment of electrolyte disturbances. Find the usual treatment will be next Wednesday, inshallah, our usual time, 9 p.m. Thank you. Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum assalam.